Okay. My screen is seen. My screen is seen.
Yes.
Yeah. Okay. Great. Okay. So good evening, everyone, and everyone that is joining from India. That is, we've got a lot of participants and a lot of interest. So good morning and good afternoon, wherever from across the world you are joining. A very warm welcome to all of you as we begin this very important discussion on perinatal palliative care. It is the eve of World Hospice and Palliative Care Day. It is also World Mental Health Day today, and we are in the middle of the week, which is the Baby Loss Awareness Week. So I don't think our discussion on perinatal palliative care and its scope, especially in India, could be done at a better time. Uh, Perinatal palliative care or perinatal care sits at the intersection of many disciplines: fetal medicine, obstetrics, neonatology, palliative care, and a range of allied specialties. When a family receives a diagnosis suggesting that their baby may live only for a short time or will have a complex or uncertain medical journey, it becomes essential that care is coordinated, compassionate, and continuous. In a country like India, which has one of the world's largest numbers of preterm births, congenital anomalies, and stillbirths, the need for structured perinatal palliative care is immense. Even a small fraction of affected pregnancies translates into thousands of families each year who could benefit from such support. The discussion today is part of a larger movement to bring awareness, structure, and advocacy to this field in India. Um, we are deeply grateful for the overwhelming response that we've had to this session. In just 4 days of putting out the flyer, we've had more than 220 registrations at last count. And this was in almost equal number from pediatricians, from obstetricians, fetal medicine consultants, neonatologists, palliative care physicians, nurses, and other professionals who all care for families and newborns. Your presence and your interest today is a testament to how many of us feel the need for this conversation. To start with, I'll just reiterate what the American College of Obstetricians and Gynecologists says about perinatal palliative care. It refers to a coordinated care strategy that comprises options for obstetric and newborn care that include a focus on maximizing quality of life and comfort for newborns with a variety of conditions that are considered to be life limiting in early infancy. Perinatal palliative care can be provided concurrently with life prolonging treatment. And this definition agrees with what the American Academy of Pediatrics and the World Health Organization also say about palliative care. So I invite all of us to hold on to that thought as we begin. So just a few quick notes before we start. I request everyone in the audience to remain muted for everyone's convenience. We are recording this session, so at the end there will be a feedback link which you can fill and we can send you the recording of the session. We will also be monitoring the chat box, so please feel free to share your thoughts and reflections and questions in them. This is just an hour discussion on a very large topic. We are just going to touch on some of the broad themes that this topic encompasses. But all of your insights will really help us shape the next steps as we take this effort further. With that, I'm going to quickly go on to the organizers. So I am Dr. Kiran Srivastava. I'm a neonatologist and a pediatrician. I practice in Mumbai and I have special interest in perinatal and pediatric palliative care. I will be one of the hosts and I will be moderating the panel discussion today. Co-hosting with me is Dr. Smriti Khanna. Dr. Smriti is an adult and pediatric palliative care consultant practicing in Mumbai. She is also adjunct faculty with the Two Worlds Cancer Collaboration, and she has been instrumental in advocating for advanced care planning, making of living wills for adults in India. Um, with us is Dr. Spandana Rayala, a pediatric palliative care physician from India who currently practices in Kuwait. And amongst her many roles, she leads a lot of mentoring and leadership projects in India and Southeast Asia. Together, our shared vision is to explore how perinatal palliative care can be meaningfully integrated into Indian healthcare, where structured programs are still quite few. Today's webinar is jointly co-hosted by Two Worlds Cancer Collaboration and the International Children's Palliative Care Network, or ICPCN. Two Worlds Cancer Collaboration works to ensure equitable access to compassionate care for people that are living with cancer and other life-limiting illnesses, empowering healthcare providers through education and mentorship. To open the session, I would like to invite Dr. Megan Doherty, who is a palliative care consultant with the World Health Organization and is also director of pediatric palliative care at Two Worlds Cancer. Megan?
Thank you very much, Kiran, and very warm welcome and good evening to everyone. I'm so pleased to be with you, joining you from Geneva, where I'm based, as Kiran said. And I just want to I'm so interested to think with you tonight about how palliative care for babies, perinatal palliative care, it sits at the intersection of, as Kiran said, so many disciplines, but also so many places in our life, at that dignity, that compassion, that presence. We need to come together, not only to share knowledge, but to build a community that listens and learns. And I really feel that we need to make sure no family walks this journey alone. These are profound moments for families, even though they may be very short. They stay with families their entire life. I have heard of women at the very end of their life, they are still going back to that moment when they delivered a baby who died or who had already died. And so this is a huge experience. And so our goal is really to bring all of that together over the next hour and start to deepen our understanding, strengthen our collaboration, and just think, how can we have a more holistic approach to supporting families, listening to what they need, what their experiences are. So thank you for showing up here today. I hope you have an open mind and open heart as we create this space to explore this together.
Thank you, Megan. The International Children's Palliative Care Network, or ICPCN, is present across more than 140 countries, and it is the global voice for children's palliative care, advocating for services, policy development, and education worldwide. I now invite Alex Daniels, who is the education lead for the ICPCN, to share insights from their global experiences in perinatal palliative care and what this might look like in India. Alex?
Thank you, Dr. Kiran. So we understand that, for the first month of life is the most vulnerable period for child survival. And we know that more than 2.5 million newborns died in 2022, according to the World Health Organization. And in the same year, in sub-Saharan Africa, had the highest neonatal mortality rate in the world at 27 deaths per 1,000 live births, followed very closely by Central and Southern Asia, with a neonatal mortality rate of 21 deaths per 1,000 live births. So today I really want to highlight the critical importance of structured perinatal palliative care programs. And this is an often overlooked yet profoundly needed aspect of healthcare. So perinatal palliative care provides comprehensive support to families who face life-limiting diseases during pregnancy and also shortly after birth. And we know that for these are some of the most emotionally devastating moments a family can endure. So without a structured program, families often navigate this journey in isolation with inconsistent care, and fragmented support. So these structured programs ensure that families receive coordinated, compassionate, and holistic care, including the medical management and the emotional counseling. But more than that, it's also about providing that includes that honors life, both life and dignity, no matter how brief that life may be. So they provide families with opportunities to bond, to make memories, and to find meaning in moments that otherwise might feel overwhelmingly tragic. And I think an important thing is, as medicine also advances, more prenatal deaths or diagnoses are made earlier, and that makes the need for these structured perinatal palliative care programs not just relevant but urgent. So this webinar is the beginning of starting this conversation that I do hope will continue in India. And as we continue to advocate for systems that support not only survival, but humanity, compassion, and dignity in the most vulnerable. Last message for those of you who joined late and see that I'm wearing a funny hat. It's because on the eve of World Health Hospice Palliative Care Day is also Hats On for Children's Palliative Care. So today we are focusing on children with palliative care needs, and we do this globally. And I hope we'll have the opportunity to take a picture with hats on a little bit later. All of us.
Thank you so much, Alex and Megan, for really underscoring that message and making my job easier. With that, I'm going to introduce our very esteemed panel for tonight. And maybe just after the introduction, we can do a quick photo. So maybe everyone can turn their videos on and then we can get on with the session. So at the outset, I would really like to thank all of our panelists for so graciously accepting to be here at short notice and for being so enthusiastic to be a part of this discussion. We have with us Dr. Pratima Radhakrishnan. Dr. Radhakrishnan is a senior expert in fetal medicine and advanced obstetric ultrasound with experience and training across healthcare systems in India and the UK. She currently practices in Bangalore. She is director of the Bangalore Fetal Medicine Center and is a renowned educator and mentor in her field. She is also the current ambassador in India for the International Society of Ultrasound in Obstetrics and Gynecology. We have with us Dr. Rajkumar Shah, who is a senior obstetrician and gynecologist from Mumbai with decades of experience in high-risk obstetrics across different healthcare setups. He practices in Mumbai and is director of EVA Medicare. Amongst his leadership roles, he is also immediate past president of the Association of Fellow Gynecologists, and he's a respected mentor and teacher to many obstetricians across the country. We welcome both of you today, and we look forward to hearing both of your perspectives. Representing neonatology, we have senior neonatologist Dr. Kiran More. Dr. More comes with a rich experience of working in and leading various NICUs across continents. He is ex-head of the department of the NICU at BJ Vadia Hospital in Mumbai and currently heads the neonatal medicine unit at MRR Children's Hospital in Thane, along with being academic mentor to budding neonatologists across the globe. To sort our legal doubts, we have Ms. Dhwani Mehta, who is co-founder and health lead at Vidhi Center for Legal Policy. She has worked on legal issues related to end-of-life care for the last decade, including judicial challenges in the Supreme Court to pioneer simplification of the process related to withholding and withdrawal of life-sustaining treatment. Hyderabad in India leads the charge in improving pediatric palliative care in the country. I'm very happy to have with us Dr. Gayatri Palat, who is professor and HOD of Pain and Palliative Medicine at the MNJ Institute of Oncology in Hyderabad. She wears many hats and holds leadership positions with various Indian and international palliative organizations, including the ICPCN, the Two Worlds Cancer, Pain Relief and Palliative Care Society in Hyderabad, the Indian Association of Palliative Care, and she's course director for the RCPCH Fellowship in Pediatric Palliative Care. She's also one of India's leading champions for pediatric palliative care, instrumental in policy change and education nationwide and in the region. Hyderabad also has the distinction of having one of India's few structured perinatal palliative programs and the only pediatric hospice called the Mandara Hospice, which I believe is the only pediatric hospice not just in India but in all of the Southeast Asia. Leading the perinatal palliative program is Dr. Archana Iyengar. She's a pediatric palliative physician with the MNJ Institute of Oncology and Pain Relief and Palliative Care Society. The perinatal program that she runs is through an MOU with the public Princess Nilofer Hospital for Women and Children, and it has grown from strength to strength since its inception about 15 months back. And we will get Dr. Archana's experience on running it and through the course of our discussion. So each of our panelists brings a wealth of knowledge and deeply unique experience, and we look forward to learning from their wisdom. Once again, I thank all of you to be here. And I will stop sharing my screen and we can probably take a quick picture. Rizwana, we could just all turn our videos on. And hats, whoever's got hats. Rizwana, let us know when you're ready.
Can I just do that instead of a hat?
I'm
That's
taking
great.
picture now.
Yeah.
One more. Sorry.
Yeah?
Yeah. Thanks, everyone.
Okay. Thank you. Okay.
Thank you.
So with that, we are going to start our discussion. So tonight, what we are hoping to do is explore what it means, not just clinically, but ethically, legally, and emotionally for us to deal with families that are dealing with babies that have life-limiting conditions or terminal conditions. And I want to just start with the panelists' experience with perinatal palliative care across their different fields. So, Dr. Pratima, you often are the first port of contact when these families have a diagnosis on antenatal scans about these conditions. A lot of times, it's not a full diagnosis, it's probably a variant on a genetic test. There is a lot of uncertainty that is involved. You've also worked across a lot of healthcare systems in structured systems like the UK and now in India. So my question is that you have a successful practice and you have been managing these families. So why is there a need for structured programs in perinatal palliative care according to you? What are some of the challenges that you face that make you think that we need a structured program?
Um, I think there are two aspects to it. One is on the bureaucratic side, which is very difficult for me to change on my own because fetal scanning comes under the purview of the PCPNDT Act. And there are so many variations in the country with regards to the rules and regulations that needs to be followed up from state to state. It varies from state to state. And so basically, unfortunately, the whole fetal scan is being made as a as a tool or a technology rather than actually humane side of it, right? Which is so very important. For example, in Karnataka, none of the woman's relatives are allowed to even come into the scan room, right? So when we actually diagnose an abnormality, there's nobody to even hold their hand, and we are all strangers to her. So this is one of the biggest challenges, but that fight is on a bureaucratic side. So there is a lot of challenges there. But on the other side, many a times when we give a diagnosis which is not very clear, there are doubts from the parents, from the families themselves, and from the referring obstetricians. And there is a disconnect many times between the obstetricians and the fetal medicine specialists and the parents themselves, right? So there is a little bit of, to some extent, there are trust issues, of course, because when you give a bad news for the first time, everybody gets shaken and they don't want to believe it. However, then coming round to it, the other big challenge, we know that many of the fetal abnormalities have to get to a genetic conclusion many a times. And unfortunately, 8 out of 10 times, we don't get to that point of conclusion. Either the parents themselves decide they don't want to, they just want to terminate the pregnancy because there are financial constraints, or unfortunately, there is a miscommunication or a misunderstanding from the obstetricians that they don't think it's necessary. They think, oh, this is just one-off thing, and the next pregnancy will be fine. So many times they are left in limbo with no logical conclusions. And to me, that's a very big challenge because many times when I see parents in the subsequent pregnancies, and sometimes the problem has happened again. Unfortunately, they have no clue why many times they have thrown away the papers because somebody has told them, it's all bad omen to keep abnormality related papers. So there's a lot of superstition around that as well. And on top of all this, many a times the woman is blamed for carrying a baby with an abnormality. And this is across board. I'm not talking about a low socioeconomic or a high socioeconomic because I do see a mixed population and a big population from the genetics clinic as well. So there are many, many challenges like that, and on each front. So I think something like this to bring all of them together, or at least some well-meaning people together, will certainly go a long way. It will take time because, as you know, India is a huge country. There are so many variations, and importantly, there are so many different schools of thought. Unless all of us come together, it's going to be a thing. But I'm so pleased to actually see this group and be part of this group. I was not prepared for so much. So I'm really pleased. And to be very honest, even I was not aware of this. I think it's time that neonatologists and pediatricians take up the challenges of actually taking, encouraging their obstetricians, and of course, because they have a close connection with parents of the siblings, uh, to take a abnormal pregnancy to its logical conclusion. And the logical conclusion is to have a proper diagnosis so that we can help them through the next pregnancy, because it has to be a continuum. It can't stop at just diagnosing a fetal problem. And this is what I keep reiterating in almost all my talks for the last so many years. So I think that highlights the importance of why I think this is really a fantastic start, and I'm really looking forward to more
Thank
of
you.
this.
Thank you so much. I think you've brought out so many aspects that, all of us that have been discussing, and probably all of us discuss in silos within our own colleagues, but it obviously goes beyond that. Dr. Shah, I want to ask you, through your experience through the years, what are some of the cases in your practice or in obstetrics that you feel merit the help and support of palliative care? You're muted, sir.
So at the outset, let me thank everybody for making this program, seen everywhere, all over the world, as well as in India. This is something which is new. And as Dr. Pratima said, that this is, for me also, this is something very, very new. This is something which I read across only yesterday when I got to know that the webinar is on this palliative medicine and what exactly it means as such. So therefore, having understood this and having discussed other issues, coming to your question pointedly, basically in my practice, where does it affect me? Yes, when an abnormality is diagnosed, and abnormalities could be anything, but the commonest that we see is the cardiac abnormalities. And here, if at all there is something which is diagnosed, then what is its outcome? A good number of times, I may not be able to give an outcome of the pregnancy. The pregnancy, fine, but what about the baby? Subsequently, what are the possibilities of this baby getting some kind of medical help, whether it is repairable, whether it will require any kind of surgery, whether it will require any kind of medications. So good number of times, these are questions which come up, which are difficult to answer in the first instance. Fortunately, we have fetal medicine experts who go through this. We take their help and probably put it across to them. In the meantime, we also discuss with the pediatricians and try and find out whether we have any avenues of managing such patients as such. So therefore, these are certain things which comes in practice as such. Besides that, there are times when besides an abnormality, an intrauterine fetal death happens, and then the blame game starts. That who's responsible for this? Why did this happen? So there's initially an anger which comes out. So that has to be handled also. So these are various things which happen during the course of the antenatal period in a patient's life. I think you are muted now, Kiran.
Thank you. Thank you, Dr. Shah. Dr. Mori, I'm going to come to you for your perspective as a neonatologist.
Kiran,
Yes,
can I
sir.
just interrupt for a minute? I'm sorry, but I have a patient in labor. I have to rush to the hospital for delivery. I'm really sorry. I would have enjoyed continuing with this, but I have to take leave of it. So everything, if there's anything specific you want to ask me in a minute or two, I can do that. Otherwise, I'll join you
I
sometime
think
later.
if you can maybe just go over some more challenges, if there are legal challenges that you face, and then we can discuss that
Yeah,
later.
so legal challenges are those basically where, like before 18 weeks or before 20 weeks, if it is diagnosed, we require that much time to discuss. At doing a sonography at 20 weeks and finding out an abnormality is a problem. Before 2021, when the new law came into force as such. So an amendment came into force. But before that, there was a problem. Patients would come and directly, if you tell them that there's an abnormality, it would be a headache for us to manage them beyond 20 weeks because nobody wants to go against the law. So therefore, now at that point of time, we would suggest a sonography done at 18 to 19 weeks to pick up abnormalities in the baby so that we get some cushion or time to discuss the possible avenues of further management as such. And then probably a termination or whatever requires to be done was discussed and was done before 20 weeks. But with the amendment of the Act, now we have got a leverage of about 4 more weeks, so up to 24 weeks. Besides that, there are certain abnormalities which Dr. Pratima will tell you that which are not as clearly seen at 18, 19 weeks, which could be better seen, or specifically the cardiac and the facial abnormalities and other things, which are seen around 20 to 24 weeks. So that is one more time as such. So then an evolving abnormality happens, then you get an extra time to find out that, and maybe the chances of managing that pregnancy further becomes much more better. But so this is the amendment which has come in, and that because of that we have been able to open avenues for termination of pregnancies before 24 weeks of gestation.
But I guess that also, so if, sorry, so
yeah, beyond 24 weeks also there are avenues as such, but then they require a longer course of action. Yes.
But I guess it also, so a baby who, if the family chooses to not go for termination but wants the pregnancy to continue or be induced, the baby has high chances of being born with signs of life. And maybe even there, perinatal palliative care, support, comfort care, all of these aspects can come in. And this is probably an option that we can now offer to these families rather than just
That's true. That's true. So
feticide.
I'll just quote you one incident which was involving me. There was a cardiac abnormality diagnosed in a woman at around 18 weeks, and she was offered termination because it was discussed that the possibility of the baby surviving and requiring further neonatal care, surgical care, is there. Having discussed with our family, they point blank told me that we just don't want to do any termination. Besides being religious, we are affording enough to manage everything as such. So she continued the pregnancy, took 3, 4 other opinions as such, and ultimately all of them suggested that this is the final opinion. So they came back to me, and God forbid, rather unfortunately, at 34 weeks she underwent an accidental hemorrhage, and we had to do a cesarean for her to deliver that baby. The baby was delivered with a cesarean section, and having diagnosed earlier, it was looked after by the neonatologist. Subsequent to that, for about a year and a half, the baby went through numerous surgeries in different parts of India for correction of that abnormality, and ultimately succumbed at the age of 18 months. So this is something which, I just remembered the moment we discussed about any kind of incidences as such. So probably if we had this kind of a care earlier available, we would have put them across to such people who would look after the baby and probably guide them properly and maybe give this a better course of action.
Thank you. I think that really helps getting your experience on this.
So I'll just take your lead. I'm sorry,
yes.
but this is something which I just can't avoid.
Sure,
Thank you.
Sure.
Thank you very
We
much.
understand. Thank you for attending. Okay, so with that, we'll continue. I'll come to Dr. More. So as a neonatologist, what are some of the challenges that you face in the NICU when you are dealing with such families and babies?
Sure. First of all, thank you again, Kiran, Smriti, Spandana, for organizing this. And I think we cannot have a better start than this. We just crossed 100 participants online, and it is such a short period of time. So definitely there has been interest, and we have been talking about this need for quite few months. And uh, since I've returned to India 3 years ago after working in different continents, I felt there's a big gap in this area, parental palliative care and also neonatal or pediatric palliative care. And great work was going on at Wadi and at current place as well. So first of all, when I was in Australia or Canada or New Zealand, the perinatal palliative care or the processes are pretty set. And the very first thing I find, and I had to prove that, neonatologists are also perinatologists. And in Australian training, I'm a board certified, where actually perinatology training is considered as a part of the mandatory part of the training. So we have to do the perinatal consults and advise parents, pregnant women with anomalies as a separate posting. So we have a clear-cut, strong exposure for this. In India, so I think getting us involved, I felt was a bit of a challenge that a lot of these cases are handled at the level of obstetrician and fetal medicine, fetal care specialists, and also in certain areas, the radiologists who are doing the fetal ultrasounds, they are sometimes counseling, and we don't get involved in discussions. Whenever the anomalies is come. Secondly, if the anomaly is surgical, the surgeons get involved, the cardiologists get involved if there's a cardiac anomaly. But I feel the neonatologist and the pediatrician is the person who is a strong advocate for that baby, who will be the first person to manage that baby after birth, and he or she will be managing all the other associated anomalies, or there could be genetic things, multiple feeding issues. That's a person who actually will be taking care of the baby. And also in terms of giving prognostication, there is a lot of variation based on where the child is born, financial status, so what kind of care child will receive, cardiac surgery done in which center, the outcomes will change. Diaphragmatic hernia, I give 90% survival. There are people who give 50% survival. So, there's so much of variation happens. And when parents wants to decide whether they want to continue or not, the person who give inputs actually is the most important person. And there one big miss is the MDT. So we used to have these multidisciplinary team meetings where the fetal medicine specialist, the neonatologist, and a concerned specialty like a cardiologist or surgeon used to come together and have a discussion and make a joint plan for this baby, and then let the parents decide they want to continue or not. If they want to continue, what will be the plan like after the delivery? So that kind of formal process is not there. It's all ad hoc. Everyone becomes an expert when it comes to something like this. The general practitioner will advise, some family friend, some non-pediatric or non-obstetric physicians will also advise. And generally, people have not seen the excellent outcomes of premature babies or surgical babies, and that's why the general outlook of these babies is not very good. So a lot of time they get negative counsel than positive counseling, and we lose those babies. So I think there's a big gap there, and programs like this, like the webinars or the training is required for all clinicians in this area, particularly to make awareness. And this is the best platform because we are bringing the obstetrician, neonatologist, palliative care physicians, and all other allied sort of specialty interest on one platform. So I think it's a great start.
Thank you. So, Dr. Archana, I'm going to come to you. So far from all the other clinicians, we've heard about, lack of awareness, lack of interdisciplinary support, and even support after the baby is born in supporting the family and in the baby. So you started the perinatal program at Hyderabad about 15 months back. So what made you start? And after starting, what are some of the learning points that you've realized, which sort of showed you the importance of having a structured program like this?
Thank you, Dr. Kiran. So we already had a well-established pediatric palliative and a neonatal palliative care program, which was established by Dr. Gayatri Pallar. So we almost have around 50 referrals of pediatric and 20 to 25 referrals of neonatology every month. So two instances made me think about perinatal palliative care when we were giving neonatal palliative care. Is that once a family, just when we were taking care of the symptoms and counseling of a neonate with the anomaly, the family told me that if we would get the same support much before we delivered, would have faced the situation differently. And there was another family who said that our baby was born. We knew that the baby won't live, but we saw that the baby was breathing, but we didn't even get to hold the baby, or we really didn't know how to. They said just you can dispose the baby. So these two situations, we felt that why don't we go much before the neonatal period and start helping the families and handhold them much before. So initially we had to sensitize the obstetricians, and since we already were having neonatal palliative care, the neonatologists and we were already working in sync together. So after sensitizing the obstetricians, we had a structured referral pattern that any mother, any antenatal mother who would be diagnosed with a life-limiting or life-threatening anomaly would be referred to us, and then we would call the family and have a counseling plan about what perception they have about the anomaly and what they want to do, whether they want to continue or just have the terminate or just have the experience of pregnancy and delivery. And during this time, it was always networking with the pediatric surgeon, with the nephrologist, with the neurosurgeon, depending on the anomaly, of course, the neonatologist, and also back to the obstetrician when we used to make the birth care plan. We also used to make a palliative care plan that in case a baby doesn't survive for maybe hours to days, then where they would like to have the baby, what kind of invasive or pure palliative care they would like, the parents would like for the baby. So all this was discussed, and we found that the parents felt very supported during that journey, even when a few mothers who lost the baby, and when we made a bereavement visit also, they said that you prepared us so much. So we only focused on the quality time that we had with the baby for hours to days or weeks. So we felt that we really benefited the families who were enrolled in our perinatal palliative care program in the last 15 months.
Thank you. Dr. Pallat, I'm going to come to you now. So we culturally, as India, we are a very social society. We have a strong social structure. We've got family, community, but we don't have very good community healthcare that is available to everybody, or even equitable healthcare that is that is available to everybody, especially for families that are dealing with people who are living with medically complex chronic conditions. So how does palliative care bridge that gap between, especially in neonatology and in perinatology?
Thank you, Dr. Kiran. I just want to talk about a few numbers. When Dr. Archana and our team started this program last year, 2024, in 6 months, we got 101 referrals. And all 85 out of 101 referrals were in the last trimester. So obviously, this is the government hospital, a public hospital system, late referrals. So by the time they came, there was no chance that we could terminate. So, and out of which, so 85 last trimester referral, and finally they were delivered. 42 lived for 24 hours after delivery. I'm just telling you the chain of the sequence, and in terms of where the spectrum of care they require. So 42 lived for 24 hours, but 43 are still on follow-up. So it's not always that they die. They are on still long-term follow-up. That means 43 out of 101 children, they're on long-term follow-up. If we don't have a community-based program, as like they're not going to stay forever in the hospital, they will go home. So if you don't have a community outreach program supporting these families, I don't think this program can do well, because we are there in the hospital momentary, like just for a period of time. After that, what happens to them? So that is one reason why we have to be in link with the community if we want to have a very successful perinatal palliative care program. Another aspect I would just want to talk about, Dr. Pratima mentioned about no logical conclusion. I really want to take from there. This no logical conclusion. This is about the current pregnancy. The family, and they're still asking this question: why? A lot of guilt, a lot of questions. Why did this happen to us? Why did it happen to me? The mother finding some reason to this, and they have a lot of cultural context. They give a lot of meaning in terms of their values and culture as to why this happened. So this is about the current pregnancy, and remember that most of them are young parents. They're hardly teenagers. So they always plan for, what if I plan for next pregnancy? If we don't support this family in the community as a follow-up of this, again, this will not be helpful. So Dr. Archana and her team, they really help all this. So they're all high risk. We can put them in a separate category and follow them up for the subsequent pregnancy, guiding them, providing adequate guidance in terms of what went wrong and how if it can be prevented, or genetic counseling, whatever need to be done. So helping with subsequent pregnancy. All this requires understanding the cultural context, community involvement, and long-term follow-up. Yeah.
Thank you. Thank you for bringing that aspect out and giving us the numbers, really, because to show us what the reality really is, and how it can make a difference. And it's not just us doctors that are needed. There are so many more people and medical health professionals, nurses, allied health professionals that are needed to deliver this sort of community and home-based care. And I know you have an excellent program. There is also a really nice program that is run in Mumbai called the Titli Home Care Program. So anywhere currently, if there is anyone who wants to reach out in these two cities, definitely do that. I'm going to come to you, Dhwani. You are a non-medical person, but as a healthcare lawyer, I'm sure you've got a lot of doctors coming to you with a lot of very specific problems related to similar situations where they're really scared about, how do we deal with such situations, and what are the things that are that can be done to prevent that. What are some of these struggles that they come to you with?
Thank you. Thanks very much for having me here. And again, like some of the participants, I mean, I think I am the newest entrant to this field and only now learning about this peculiar complexities that arise in the context of perinatal palliative care. I've had the chance to work on end of life care issues generally for a while. And so, what I will do is maybe share some of the misconceptions and fears that members of the medical fraternity in India specifically have in that context. I'm sure there are uh, more and perhaps slightly different concerns in the context of perinatal palliative care. I may not be as familiar with them, but I know that there will be a lot of similarities. So some of the common issues that do arise is I think misconceptions about what the law permits and what it doesn't. I mean, I think there is still a very large misconception around the most fundamental one, which is that withholding or withdrawing life sustaining treatment is a form of euthanasia or is akin to murder or involves killing someone. So these are some of the terms that are used. They are obviously harmful in an emotional way, but they also carry really damaging consequences because each of these terms has a specific legal meaning. So it's a bit careless to be throwing around terms like this because they contribute to the kind of fear psychosis that already might exist amongst the non-enlightened members of the medical profession. And by that, I mean, I don't mean to denigrate anyone. It's just that the knowledge and awareness about this issue has obviously not percolated as far as we would like it to. The other misconceptions are that there is that everything must always be done with the only intent of preserving life. I think a lot of, apart from the Hippocratic Oath, I think a lot of doctors also believe that this is what their legal obligation or duty requires. That is not necessarily the case. I mean, I know, and during the course of the talk, I can come to some specific cases where principles like this might have been mentioned and sort of point out why they should not be interpreted in that way. But the conception is not that the appropriate treatment must be provided or appropriate care must be offered, but that everything must be done with the sole objective of saving life. And I think this perhaps becomes more and more important in the perinatal palliative care context and worrying about whether every intervention must be undertaken or whether comfort care should be provided. Other misconceptions are, I mean, not misconceptions, but I think there is obviously confusion about identifying the person in charge who is responsible or has the legal authority to take decisions for the patient. And again, that can be compounded in the case of perinatal palliative care, where there are presumably in most situations at least two legal guardians, i.e. the parents, and whether one has authority over the other, whether they jointly have to take decisions or not. There is confusion around this, and the law also is not particularly authoritative or definitive around this. The other misconception is that discharging patients against medical advice or allowing them to leave without providing appropriate transit care or referral, etc., will protect doctors from any and every form of legal liability. So this is the other I mean, I think this acts often as a barrier in providing certain kinds of comfort care because the choice is then presented as a binary. Either I provide every aggressive intervention possible, or I discharge this patient or leave this family to their own devices because that is there is no in between that is permitted. And then finally, of course, there's the normal general fear that exists, I think, amongst any medical practitioner, which is that what the fear of criminal or civil action if they get a diagnosis wrong. I think this is especially true in cases where the prognosis may be uncertain or it is not possible to predict exactly what the outcome of a particular child who will be born will be, and how and whether they will be held liable if the child survived longer than they had predicted. I know a lot of doctors often come to me with that question, or what will happen if there is tomorrow another advance in medicine that is made, which they had not predicted, and therefore, they had offered the incorrect advice to the patient. So these are some of the common misconceptions and fears and concerns combined.
Thank you, Dhwani. I think you say you're the newest here, but I think you've really picked the pulse of most of the issues that we all face. Um, you spoke about how we talk to parents and what are some of the terms that even we as doctors use. And I'm going to come back to you, Dr. Pratima, and I'm going to ask you in whatever way. I know there are you alluded to some of the limitations that you have, but what are some of the things that you do in your when you're communicating or breaking bad news to your patients? What are some of the things that you sort of take care of, or you hoped ideal? What would an ideal situation look like?
Um, Many times, when I'm actually scanning the patient, scanning the fetus, the moment we see the abnormality, many times we just turn silent, because then we want to kind of get get all the information of the fetus and things like that. And the moment they sense that, the mother starts asking, what is something wrong with my baby? And I think the first thing I learned from my professor is to be honest with the mother, absolutely honest on the spot. I tell that, look, I think there seems to be a problem, and just give me some time. Let me figure out what it is, because I have to get it straight in my head before I can tell you. And I do encourage at that moment of time, I certainly encourage the patient, the mother's husband, I mean, the woman's husband or her own mother who might have accompanied her to the clinic to come inside the scan room and be with her. Because I think that, because at this time, it's not only about her getting anxious, I also need all her attention so that I can tell her everything that I need to tell her. Because, and also I make it a point that I don't talk everything in the room, because of course many times, because mine is a training unit, I have got other people surrounding me, and even if it is not, sometimes the nurse is sitting there and we don't know the confidentiality, how the parents will react. And so we have a separate counseling room, so I take them to the counseling room. I give them a little bit of time. I don't go immediately. I we sit down and break the news gently, and I always start with, look, I have got bad news for you, and then start talking. I don't beat around the bush. I think it's the worst thing one can do, is to beat around the bush, because by this time they have already figured out there is something terribly wrong, and all they want to hear is what is the problem and is there a solution, right? And even if there is a solution, or even if there is no solution, both ways you have to tell them, right? And many times in fetal medicine, particularly, we don't have the luxury of time, right? We have limited time that we can, and there are no, I don't wear a watch. There is no clocks anywhere, because you need to spend a lot of time with this couple. And we do have, actually, interestingly, I was listening to the other speakers, we have a counselor who's been working with me for almost 20 years. And I just trained her as a counselor. She was a regular counselor, she's done counseling. And then I just said, you come and sit and observe my abnormalities, because I need somebody on whose shoulders the mother can cry. And then they all sit in the room and they are given time to think through it, digest the problem. And of course, we always give them a option to come back and talk as well. Many times they're very vulnerable at that point of time, and they can't make very quick decisions. And of course, there is absolutely never a rush to terminate the pregnancy. I tell them that we are not talking about termination. First of all, we need to get through the problem. If it's a cardiac problem or a brain problem, many times we need other specialities. We need to cross refer to the other specialities. And it is good practice. I mean, I do refer them frequently to the pediatric cardiologist or the neurologist, or if we need an MRI, get an MRI done. And all that is available in almost all cities, it is available. And fetal medicine centers, units should be tied up to these places, right? And that regular crosstalk has to happen. And very importantly, of course, we need to involve the obstetrician, inform them as well. But many times I am the person who's giving the bad news to the thing. And so I have to be completely aware of what I'm talking about. Now, one of the challenges that I find, and I think Somebody alluded to that as well. I think Dr. Kiran More alluded to that as well. The neonatologists, we have the same problem. There are fetal medicine specialists who are qualified, and then we have fetal medicine specialists in court, right? Who think they know, but unfortunately give the incorrect information many times. And many times it's difficult to undo those things, right? And this is a line that we have to trot along. And I always say this is the storm before the calm. In maybe 15, 20 years, things will get better, will get more channelized. But fetal medicine is such a new branch. It's been around for less than 20 years, and it's a very young branch, I would say. Very similar to neonatology, I guess. Neonatology is, usually it was the pediatricians who were looking after the neonates. But anyway, coming back, so I think you have to have a lot of compassion, a team sit there to talk to them and give them opportunity to come back. The first instant never has to be termination, never has to be termination. Even if they are sitting on 23 plus 6 days, the law is there to help you. And if it is such a bad condition, the law, you can apply to the medical board. And my experience has been very good with the medical board. They do give permission, provided you have the right, reasons to discontinue the pregnancy, right? And I think the awareness is lacking. More and more people need to be aware, because many times parents come to me, they want a super urgent appointment tonight itself because I'm 22 weeks and my obstetrician has told me I have to, make a decision right away. It's not that, and these decisions cannot be made overnight, or over the conversation. Then they're already so vulnerable. So they must be given time to think through this, and then come back in peace and discuss again, maybe a day or two later. So fetal medicine specialists cannot see 50 patients in a day. They may see about 15 to 20 maximum, and that has to be, sorry, I think there's a lot of noise. I'll come back to it. Maybe you can take another question till then.
Kiran, you can mute everyone, I think, and you can control that, mute and unmute, Kiran. You're a host.
Okay.
No, Dr. Kiran, I'm in the airport. That's why
I think there was an announcement that was going
okay.
on.
There was an announcement was going on at the back. So, so coming back, so I think, the more we talk about it, the better we will get for sure. Because I have seen nuchal translucency go from nowhere to something that everybody talks about, including neonatologists and pediatricians today. So I think it will change. I'm very optimistic.
Thank you. I think you've brought about some very actionable points actually that all of us can take home on communication and being honest with patients and really being okay with saying that I don't know. And sometimes parents and families just appreciate that. They just like knowing that you are there in that sort of journey with them. And I know you're at the airport, so I just want to get a word in from you on the mother's mental health and perinatal mental health. And you said that you've got a counselor. So I want to ask you about guilt or regret that such families and especially mothers may feel, because there is a huge lacuna in even counseling or even for all of us as medical health professionals looking after mothers and or thinking about the mother's mental health. So I just want to talk about that and how these diagnoses affect
it's
women.
absolutely, you hit the nail on the head, Kiran, because it's very, very important, because majority of the mothers, they feel guilty. And unfortunately, the societal structure makes them feel guilty as well. It is induced upon them. And I in fact make it a point to tell both the parents that it is nobody's fault the baby has a problem. It could be anybody, and it is nobody's fault. And unfortunately, it is just your bad luck that it has happened at this point of time. Right? And I think what we tell them goes a long way. Majority of the people who have, unresolved trauma, who are the ones who come in the subsequent pregnancies, saying that, what I think Dr. Archana also brought up that issue, that I could not hold my baby. I did not see my baby, even if it was 24, 25 weeks, it's her baby, right? A woman never forgets termination, never ever. 5 weeks, 6 weeks termination, they will give you the history, even if it's for social termination. I think that we need to understand that it's not an easy decision for them, and having to go through an induced termination or having had a baby with an abnormality and they're not made to see the baby and thrown away the reports. These are all societal problems, and the changes have to start from a very, very basic level. And the pediatricians and obstetricians are actually their family doctors as well, right? Majority of them want to go back and discuss with their obstetrician, or they want to go back to their the siblings pediatrician and discuss with them. So unless that comes from them also, it's not going to change that easily. It will, but it will take much longer. But I think the fact that the mother has to be told again and again by the people in front of the whole family that it is not her fault, and it is not the husband's fault also, because he should not feel guilty either. We do see a lot of people who have genetic problems and they are carriers. And this specifically applies to them because many of them would have married within the relation. So obviously there is marital disharmony as well. And in addition to the problems that we tell them that there is a recurrence and you are a carrier. So how we talk to the parents goes a long way, really. Right. So I think we all need to do communication courses as well.
Thank you. Thank you for bringing that out, and really just the repercussions of, what it is. And even in the NICU, just when we are counseling parents and just telling them whatever the reason may be, just that one line that it's nothing that you did makes such a huge difference. Just, the look on the mother's face changes. Generally, they're always crying because they're carrying all of that guilt, sometimes quietly. I'm going to come to you, Dr. More. And someone's mentioned parallel planning in the chat. So I want to ask you about how you go about parallel planning in cases where there is prognostic uncertainty, antenatally or in the NICU.
Again, as Dr. Pratima said, you have to be really honest and very transparent, whatever you are sharing. And when it comes to parallel planning, I mean, you have to give them both options and let parents decide what option they want to go for. Suppose nowadays, obviously, a lot of surgical things are available, a lot of options are available for any complex surgical heart as well. But, as it was discussed earlier, that one patient underwent under a lot of surgeries. So we have to prepare them to go through that path. Suppose they have financial capacity and willingness to go through that path and go over a lot of surgeries and still face the outcome which is uncertain. Or from the beginning you give a parallel option of going for a palliative care from the beginning, and so again it is lot depends on parents wishes, what they really want, what is their situation is like. If this baby, suppose it's a precious pregnancy, they've been waiting for 10-15 years, they want to do everything, or they're okay to go for the palliative care pathway. So I think we should give them both sort of options as a parallel planning, and let them decide. And you just be a supportive person, put the right information in front of them, give them both the options, and give them time to decide. A lot of time the first meeting may not be the best meeting for them to decide, so you introduce everything for them, give them both the options, and let them think about it, talk to their family members, and come back, and we can again discuss that. So that's generally my approach.
Thank you. So thank you for just bringing out. One is parallel planning, again, being honest, and then also family-centered care, not just in the NICU, but even antenatally, thinking of the baby as part of the family where it is born, in the setting that it is born. Dr. Gayatri, I would like to come to you. Generally, palliative care is, even amongst medical professionals, if you introduce the term palliative care, they think of it as giving up end-of-life care. Families are not very comfortable with the introduction of palliative care. How do we go about that? How do we introduce the concept of palliative care as not just end of life care?
Thank you, Kiran. I think it's I may not even use the word palliative care there. I will bring the concept of suffering. So what I would like to emphasize, what I would like to tell them is that, like, when you speak about, again, going back to parallel planning, best and worst case scenario, whatever happens, regardless of the outcome, I don't want the baby to suffer. That language they understand so well when it comes to suffering. While we're trying all these things, can we make sure that the baby is taken care of and baby is not suffering? And for that, we will be able, maybe we will be able to help you. So that's the kind of stand I would take, and that's usually acceptable for them most of the time. Yeah.
Thank you. Dr. Archana, ma'am spoke about suffering. Can you give us some ways that we can um, provide comfort care, reduce suffering, reduce pain, even in babies, even in fetuses? There is a misconception that neonates or fetuses don't feel pain, which is not true. So, what are some of the things across settings, so low resource settings, that everyone that is joining in can implement?
Yeah, so coming to comfort care, it can be pharmacological or non-pharmacological. Again, depending on the anomaly, the system, it might be pain, which we assess with NIPS and PIPS scoring. It might be good symptom management in case there are tremors or seizures. For example, if you have a baby born with hypoplastic pons or absent worms, the baby will start having tremors on day one. So such kind of symptom management, or if the baby is having breathlessness or going into end of life, then medications like opioids we use. If there are a lot of secretions, we can use glycopyrrolate. Coming to non-pharmacological measures, as already said, it's always fathers and mothers touch and caressing the baby as much as possible can give the best comfort care. And also we encourage non-nutritive sucking or KMC in a baby who either the mother, the father, or the grandmother. And in case in comfort care, again with babies with ruptured meningomyelocele or a wound, then again pain management with a good dressing, that kind of comfort care is encouraged. So this comfort care can be given in the hospital, or it can be given at home or in the hospice in case of parents are not very confident enough to take care of the baby at home. So it's done both with pharmacological and non-pharmacological management. Coming to cardiac conditions, in case a baby has a spell, then again we use opioids. So depending on the condition, then the care plan is made, a crisis plan is made, and also an advanced care plan is made that in case the baby is going into end of life. So our main goal will be to give good symptom control and provide a good death and good end of life care in case we identify that the baby is dying.
Thank you. I think allowing family and having family around really makes a difference, especially if the baby we know is probably not going to live for sometimes a few minutes to hours. And I think sometimes what we don't realize is a lot of these babies that are born are just known by us and the family. No one else knows them, and especially in bereavement support, which is why it's very important that someone from the team who's spoken with the family from the beginning is there to speak with them, because sometimes we are the only ones that have known their baby along with them, no one else. And I think that is something we need to remember. I'm going to come back to you, Dr. Pallat, really quickly, because ma'am spoke about opioids, and we have very strong narcotic laws. So I just want to know from you, from a policy level, what are some of the challenges that come, and what are some ways of maybe circumventing those or resolving those?
I think today we are lucky, at least in India, that our laws are more friendly towards medical use of opioids. So we have a very central regulation, and it's not like state decides in their own things. It's a very central common law for all of us to follow, and so, and which is much more friendly compared to before, since 2014, which got the law when everything opioid regulation got amended. And so today when we apply for this, according to amended regulation, recognized medical institution status, once we get that status, there's some guidelines, and so you can apply to get the all the essential narcotic drug which comes under that umbrella, which includes morphine, methadone, fentanyl. So, and especially when you're speaking about perinatal and neonatal palliative care, we need opioids there too. And contrary to what we believe, without opioid, we cannot give good perinatal or neonatal palliative care. We see so many painful conditions in neonatal. Classic example is epidermolysis bullosa or osteogenesis imperfecta. So painful, like we can't even hold the baby. It's so painful. Or as Archana said, a baby who's dyspneic or baby who's into cyanotic spells. We need opioids. So for all of this, if you're planning towards any palliative care, neonatal and perinatal program, parallelly, we have to think about, along with training and education, making opioids available.
Thank you. So I'm just seeing the time. We are over an hour. I'm just going to come to Dhwani very quickly. So in terms of documentation or other ways in which, what are the things right now, given that we are all in a gray area, what are some of the things that we can do at our end to safeguard ourselves while offering the best care that is possible to these families?
Sure. Sorry, I was just in the process of replying to one of the messages in the chat as well,
Oh,
which was about
sure.
no, but I think maybe I will weave that into my
Okay.
response, because I think now with documentation and processes, the first thing, of course, is to be more aware of what the Supreme Court judgment says around withholding and withdrawing life support. There is I think the first question that is often asked is whether this applies to children or not. As you will have seen, I have replied in the chat that there is nothing in the judgment that explicitly mentions children, but there is absolutely no reason to exclude its applicability to children either. Children are persons just as much as any other human being, have the same right to life and the right to die with dignity, and it would be an unethical and illegal interpretation of the judgment to say that it doesn't apply to children or that you can't withhold or withdraw life support in children. So that is the first. Now, the judgment does put in place a complicated process for withholding and withdrawal. For those who are not aware, this involves decisions by two sets of doctors. One, the primary medical board, which can comprise the treating team, and the second, a secondary medical board, which should have a doctor nominated by the district chief medical officer. So for those who are joining from other countries, this is a government doctor, an official post, and they nominate someone to take this decision. Ultimately, then that decision has to be intimated to a judicial magistrate. Now, in practicality, I think there may be a lot of withholding and withdrawal decisions of different types and kinds. There may be decisions that have to be made in the spur of the moment, where I argue that it would be impractical to apply the court's judgment to, let's say, an emergency cardiac arrest, where you have to decide then and there whether you are going to provide CPR or not. Now, if you look at the court's judgment, it allows you 96 hours to arrive at this decision. I argue that it is not intended to apply to emergency decisions at all. However, in cases like this, and let's consider, I mean, from my own understanding, as brief as it may be, of this issue, it seems that in cases like this, where there are decisions taken not to terminate a pregnancy, and there is a possibility of anticipating what the prognosis might be, and also the time for the family to understand and decide what their future course of action might be, there is actually this, in some sense, the Supreme Court judgment is perhaps can most likely be implemented in these kinds of scenarios, because there is a possibility then of having that time where you can convene a primary board, a secondary board, and decide and document that this is what you have explained to the family, this is what they understand the situation to be, this is how they decide, this is what they have decided regarding what the care it is that they would like to. Therefore, it is possible to take these decisions in compliance with this court directive, as tedious as it might seem. And in fact, Sir Gangaram Hospital in Delhi has actually included in its end of life care policy a provision for having in place DNAR orders or an advanced care plan in situations precisely like this. I mean, of course, apart from Veronique and Smriti, who've already been discussing issues related to this in the context of pediatric palliative care, I think people are beginning to be aware now that this can be applied and documented appropriately. And if you look at that policy, there is in place a particular protocol. So, once there is an internal hospital policy, there is an intent and a appropriate way provided to follow that Supreme Court judgment. All of these experts do sign off on these decisions. Once all of this is documented and put in place, there really shouldn't be any risk of legal liability at all. So, but at the same time, I want to say this. I don't mean to say this in a way to spook people, but just to give people a sense of how difficult it is to explain this to lay persons. Because a few weeks ago, I came across a situation where I was asked my legal advice on cases where someone, and again, I think this was a person or a bureaucrat not entirely well educated about the issue at hand, who worried that having in place, let's say, an advanced care plan for a child in this kind of situation could be interpreted as circumventing the time limits for the termination of pregnancy under the Medical Termination of Pregnancy Act. So there was a fear in his mind that this was a way for parents and doctors to collude. If the pregnancy couldn't be terminated, it would be carried to term, and there would be an immediate decision not to resuscitate, and that would mean that that would amount to culpable homicide. Now, I think there are lots of there's a very easy way to refute this. As long as doctors are providing their informed medical opinion on what the prognosis is, what the treatment outcomes are, what they think is actually in the best interest of the child, and if this is documented and confirmed by other independent experts, there should be no question of legal liability or medical negligence or circumventing the MTP in any way. So I would say that I'll just say my piece here. There are always two conflicting principles, I think, in the context of care for children. Does parental authority or their prerogative to take decisions for their children trump what doctors believe is to be in the best interests? We don't always, the courts don't always give us a clear answer in this regard. But if you are to look at the general case law and precedent around guardianship, wards, whether in medical or non-medical contexts, you would err towards doctors acting in the best interests of the child. So in situations like this, where there seems to be a conflict between what the treating team would be suggesting and what parents would want, I would again recommend that there are repeated rounds of communication until consensus can be arrived at, and if it can't, then there is recourse to the High Court. For example, for those of you who've worked in the UK and in other jurisdictions, you will know that there is a humane judicial system in process precisely for difficult decisions like this. We don't have that in India, but we are beginning to see more of that with MTP Act cases. And my sense is that if even with cases like this, I'm sure that the judicial system would respond appropriately. So sorry, I think I've mixed up a lot of things that I wanted to say in one answer. So I will stop here. And if there are
No, thank you. I think you've gone over a lot that we really need to discuss, and we are almost at the close of the session. So there is so much more that needs to be discussed. I think we can have probably 2-hour long sessions with each of the panelists. I just want last comments from each of you, maybe under a minute. I don't know if Dr. Pratima is still with us. I can still see her. If, ma'am, if you're still there, if you've still got network.
I'm here. I'm here.
Okay, so just closing
I'm still here.
closing words.
Just 1 minute, Kiran. You take the others
Sure,
one. I'll come back to
sure.
you.
Dr. More?
Yeah, sorry, I was just attending a patient. what do you want to just say some
So
final word?
just closing words. What maybe are what are some of the solutions, or what is the way forward? Quickly.
Yeah, way forward. Yeah, I think first of all, I mean, what we started this is a good thing. Like bringing people on one platform. We should have some regular meetings, having some courses. I think some people are already sharing some existing courses, and it was very enlightening and happy to hear like Dr. Archana.
Oh, I think Dr. More is dropped off. Dr. Archana, do you want to take over?
Yeah, thank you, Dr. Kiran. So anybody having a neonatal program, I think you should go a little bit ahead and also start perinatal palliative care program. And we are lucky that we presently have 192 families for whom we provided perinatal palliative care, out of which 118 babies are alive and under follow. The rest of the babies, we gave them comfort care, symptom management, and end-of-life care wherever the families wanted. So I think any center should have this kind of care, and then only it will be complete pediatric palliative care. Thank you.
Sorry, I just got lost at the wrong time. But yeah, I would just say thank. A lot of people have already said. Yeah, meetings, regular meetings, some kind of courses people can attend. Maybe I think Vero, I saw Vero is there already. You know, in Mumbai also we have a couple of centers, especially Vadia, doing a lot of good work. So people who are interested to come into this perinatal or palliative care, I think we need more physicians, advocates for this, and again, improving just in general awareness in all specialty like fetal medicine, obstetrician, and pediatrician, and bringing them together. I think that this will help. That's it. And
Thank
great
you.
start. Yeah, thank you. Great,
Thank
great
you.
session today.
Dr. Gayatri.
Yeah, so I just want to reiterate what the World Health Organization recommends in terms of establishing any palliative care program, which also applies to perinatal and neonatal palliative care. You need to have proper training and education. One side of the triangle, the other side of the triangle is essential medications, availability of essential medicines, and the most important, having a policy. If you're working in a hospital, or for the policy for the state, for the country, but having a proper policy in place. Policy includes everything around the program, as well as policy around end of life care, and some guidance around all ethical dilemma. And not just having the policy, implementing it effectively. So just having it on paper doesn't work. So having a proper effective implementation. And you cannot work in isolation sitting in a hospital. If you want the program to be effective, you have to connect with the community outreach program so that you provide care for the children wherever they are and whenever they need it. Thank you.
Thank you. And I'm just going to bring in, because I can see Dr. Veronique Dinand is joining us. So she heads the pediatric palliative care department at Vijayawada in Mumbai, and she's got a very nice home care program that really extends across Mumbai and really helps a lot of their cases, a lot of our cases that we refer as well. So, Dr. Veronique, if you just want to come in maybe with a few comments. I know we've not been able to take any comments or any questions from the audience.
Yes, I think that it was also mentioned the same as at Hyderabad. We need to be able to go into the community to continue the care for those families and those babies, perinatal and neonatal. Most of our babies do not survive long, those on perinatal palliative care. But I think it's wonderful to have here obstetricians, pediatricians, palliative care physicians, neonatologists who get together and let's continue the momentum. I think those meetings would be wonderful, not to continue and strengthen perinatal palliative care in the country.
Thank you. Dr. Pratima?
I think Dr. Pratima has put her message in the chat.
Okay.
I did. If you can just read out my message, that would be great, so that people are not disturbed by my noise.
I will do
Background
that.
noise. Yeah.
Dr. Pratima has said that she would like to emphasize on proper, well-informed communication, and this needs to be started very early in medical school itself. Dr. Pratima, it's almost as if you are a palliative care physician.
Thank you. So I think we're going to close the session now, because I can see the chat had a lot of questions, and Smriti, thank you for handling them, Vidhi and Vero as well, answering them. Um, I think this is just the beginning of a conversation. I'm going to hand over to Dr. Smriti just to talk about some resources that are available and some things that hopefully we will also be able to offer in terms of education. And I've also put some resources in the chat. Um, and I've put so this is a feedback. I've put the feedback link in the chat as well. We'll send you some more resources and a link to this recording so that you can, if you want to go back to it or share it with more colleagues, please feel free to do that. Dr. Smriti.
Thank you, Dr. Kiran, for that excellent moderation. And thank you to all the panelists and all the other eminent speakers who joined. Some resources have already been put up on the chat. We in India have been very inspired by the work that ICPCN has done. They have recently come up with a new neonatal online training program, and that has also inspired us to explore a more multidisciplinary training program involving all stakeholders, which is what we are planning to design and hopefully start early next year. And this way, we hope that we will not have perinatal palliative care just restricted to the few centers that we have been discussing, but in all over India, and hopefully also at more places in the world. Some of the discussions that we have been having has been focused on the fact that actually we have a very diverse healthcare landscape and we have to make room for all. So whether it is community, periphery, urban, rural, tertiary care, primary care that we are looking at, we are looking to have a training program in the next year that will focus on the medical aspects, the ethical aspects, the communication aspects, the immediate, the antenatal aspects, and the immediate postnatal aspects. And hopefully this will be a program that will be open to fetal medicine specialists, obstetricians and gynecologists, palliative care providers, and pediatricians and neonatologists. I heard that somewhere nurses, a question about a program that will involve nurses. So watch this space for more. We have your email IDs. We will be announcing the program soon as we have designed it and planned it a more comprehensive one for all of you.
Thank you. I just realized I've not asked Dhwani. Dhwani, any closing words?
Yeah, I mean, I just think that there is need for better guidelines from the associations not better, I just mean that guidelines, informed and updated guidelines from medical associations can play a very important role in clearing fears and misconceptions about legal liability. They can end up informing the law. So don't wait for the law to be proactive. Do whatever you need to do as medical professionals, and then hopefully that will act as a needle to moving the law in this case. And I mean, one last thing, of course, there is we don't have I don't know if we have representatives from government here on this panel, but in your introduction to this topic, Kiran, I mean, for me personally, it felt like an incredibly unjust health inequity that there are different guidelines depending upon the different facilities in which children are born, and this is positively a duty of the government to take up and to provide to provide access to health. So I mean, I can't imagine anything more inequitable than this. So if there is any way for us as a group also to advocate for this in some form, I would be again very happy to assist with that.
Thank you. I think you've tied it really well, and we've closed it. Dr. Pratima started with bureaucracy, and you've come back to that point that we probably need a system change. There's a lot that we've not discussed today. We've not. It was mostly a medical panel today. We've not even spoken about the nurses, the psychologists, the various other allied professionals, physiotherapists, occupational therapists, and government officials, policy makers, administrators who really make a difference to how we cared for these families. And we've not spoken about ourselves. We've not really spoken about self-care. So I think it's important we also think about that. We do, and we take these decisions, we deal with these families on an everyday basis. And just because we do it every day doesn't mean that it is easy to do. So I request all of you that I hope all of you have learned something, at least one thing, that from this discussion today, and you will be able to share that within your colleagues, within your groups, within your teams. And thank you everybody for joining, the panelists and everyone else who've given almost an hour and a half of their lives. And hopefully we'll reconvene again with more such discussions and more resources. Thank you.
Thank you, everyone.
Thank you and congratulations, Kiran.
Thank you. Thank you very much.